Healthcare loves success stories. Boy, does it love success stories. We publish them, we present them at conferences, we build campaigns around them. But here's a question that I don't think is often asked or asked enough. What exactly do we mean when we say something was successful? Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we look at the issues spreading across healthcare and what it takes to implement them wisely and sustainably. So I want to spend some time today talking about a positive innovation, a positive trend, something that was successful, and then tease out this idea of what does it mean to be successful? How can I call it successful? What is that all about? And it's really interesting. The one example I want to use is the ABCDEF bundle. Yep, that's a big mouthful. I'll explain it in just a minute. But in my experience, and based on some of the activities in the literature, it was successful innovation, made major differences in how healthcare was operated in the intensive care unit. We call it a successful intervention because a lot of organizations are using it. More than several hundreds of ICUs across the country have implemented, and it's a moderately complex improvement initiative. It's not one of the simple ones. It's not one of the you do one thing and makes a big difference, or do two or three things. So what makes it really interesting is not just the results, but how those results were achieved. First of all, for some of you, you might know that it's also called the ICU Liberation Bundle by the Society of Critical Care Medicine. And the Society of Critical Care Medicine had a big learning collaborative about it and did great research on the impact and the effectiveness of implementation. But before we get into any of that, let me get back to the basics and talk about what is the ABCDEF bundle. It's kind of like your little kid going through the alphabet again, but that's part of the magic of all of it. So first, A is about assessing, preventing, and managing pain. So assessing pain. B is both spontaneous awakening and spontaneous breathing trials. And remember, this is in the intensive care unit. These are for patients on a ventilator, so very sick intensive care unit patients. And B was spontaneous awakening and breathing trials. C was the choice of analgesia and sedation. It's interesting. There's lots of research that what types of analgesia and how you deal with pain and those activities make a difference in the success of people doing other activities and getting off the ventilator. D is delirium assessment, prevention, and management. And this is a real breakthrough. We used to think that delirium was the combative patient, the one who was always fighting. In fact, sometimes they got sedated, but it turns out statistically that it's more sometimes the inattentive patient, the patient who's just not there, that has a bigger chance of having delirium misunderstood and mismanaged. E is for early mobility and exercise. And I know this is going to sound strange for some of you, but yeah, you can be on a ventilator and actually be walking around. And certainly you could be becoming mobile. And that makes a big difference to getting out of the ICU early. And F was added on at the end, and that's called family engagement and empowerment. It's interesting because, the family oftentimes spends more time in the ICU with patients than anybody else, and engaging them as partners is real critical. So none of these ideas were revolutionary in their own. And in fact, more than 35 randomized controlled trials existed to support these practices when it was first named by our friends at Vanderbilt University, by Wes Ely and his colleagues there. What the bundle did, the bundle made it easier to understand. It made messaging easier. All the stuff we talked about on the UP campaign a few episodes ago. Once people can get their arms around it, they can generate some enthusiasm for it. When you're looking at 35 randomized controlled trials, you don't even want to start reading them because of the commitment that it requires to do that. So the brilliance of this bundle was how it simplified and made it easier to understand how we do some innovations. So let's talk about some of the results. The largest study, and there's been many studies about the ABCDEF or ICU Liberation Bundle, but the largest study was, it looked at 68 ICUs, 68 intensive care units. That's across multiple institutions. Very hard to do those well and accurately. 15,000 adults across 68 ICUs. Here's what they found: 68% lower odds of hospital death within 7 days. Not just, staying in the ICU forever, but death. 40% chance lower odds of delirium, 63% lower odds of physical restraint use, 46% lower odds of ICU readmission, and 36% lower odds of discharge to facility other than home. Last one's kind of a big deal. You may not think it's so bad to go from a ICU if you've been in there for several days or weeks to a nursing home, but it turns out if you go home, you're more likely to stay at home and you're less likely to have a readmission. And that's really important because post-ICU syndrome is a big deal. We'll talk about that on a future episode. What was kind of interesting in several of the studies was that there was a dose relationship between how much of the bundle you implemented and implemented well. And it looks like every 10% increase in bundle compliance or bundle use had a 7% higher odds of survival. So for partial compliance, it was 15% higher survival. What that meant was we should look at success more broadly. It's like, did you get 100% on every one of the ABCDEF bundle elements? They're good. You should try to do that, but it's sometimes really difficult, especially the mobility, and we'll talk about that in a future episode. So what was it about this that spread through hundreds of ICUs that was relatively complex? As you could hear me describing some of the elements of the bundle, what was it that made it be implemented when others didn't, especially some of the ones that I've talked about in the past? So here's where things get kind of interesting. There was a strong evidence base, and there's no question wherever the evidence base is squishy. And we've talked about that a little bit with sepsis, with fluids, because the data on that bounce back and forth. If there's a strong evidence base, much more likely, but that's not enough. We know from data and experience that just having a strong evidence base doesn't actually accelerate it. It's a contributor, a facilitator, a clear framework. So the ABCDEF or ICU Liberation Bundle was pretty easy and straightforward. It wasn't hard to understand the components of it. So the complexity wasn't in the framework, it was in the implementation of it. It had practical implementation, and I'm going to talk about a little bit more about that in a few minutes and also on a future episode. It had interdisciplinary ownership. So it wasn't just the nurses. It wasn't just the doctors. It wasn't just the respiratory therapists. It was kind of everybody took it into hand. And so that was really important. That had consistent measurement, and there were very good measurement capabilities that were relatively easily done. And you can contrast that with what I said previously on my episode about the UP campaign, where we really didn't have good evidence of measurement. It had clinical relevance because everybody knew when somebody got stuck in the ICU, it was really difficult. And the longer they stayed in the ICU, the harder it became to liberate them or to get them out of the ICU. So unlike many campaigns, it wasn't just about messaging. Yes, messaging was in there, but it also changed behavior. So here's the question that you want to talk about. When organizations talk about success, what are they really measuring? Do they really have good examples of great outcomes? Are you measuring awareness? Or are you measuring adoption or participation or outcomes? Or maybe you're saying, can we do this over several months to years? They're very different things, and we need to think about them sort of in much more rigorous, structured fashion. We've talked about in the premortem creating some objective milestones and measures, and determining success of an intervention is really critical to having well-described measures. Many organizations, I want to say, have these key performance indicators. Some even have implementation success measures. But if you really look around to see what people are talking about success, what I found in many cases, it's much less than ideal. And the really only way to know whether something was successful is to look backward after time has passed. And that's kind of the way the ABCDEF bundle was. We've had now a decade or more to be able to look at it. And we can see that it's sustainable and made incredible outcomes improvement. Some of the interventions and some of the trends we talk about, it looks good in the beginning, but it doesn't necessarily sustain or increase or drive the outcomes we're looking at. So there's kind of this hierarchy of success. And again, this is the soft, non-quantitative Bruce talking right now. It's more qualitative, but it's really important to think about it in this sort of level of or hierarchical way of thinking about success. So level one is when people know about it. And that sounds like easier said than done. And it's kind of interesting because sometimes that people know about it are in isolated pockets of an organization, especially if you're a large organization. I ran a meeting once where we had an organization that had more than 10 hospitals, and we had them all in a room together, and we highlighted one hospital that had this great activity. And I would have to say 7 out of the other 10 hospitals that were there from that same organization had no idea this was going on. So people knowing about it is the first level. It's important, and spread throughout the organization is an important component of that level. Level 2 is that people like it. And part of the reason they like it is because it makes sense. It's intuitive. It has face validity. It has some actual data that supports it. Then level 3 is people say that, let's try it. I want to try it at my organization. They did it there. Let's see if we can do it here. And it goes back to this idea that this change and implementation and innovation is a social phenomena that we see as we look at other organizations, other people. Level 4 is it becomes part of the way they do work. It is consistently used. So people consistently use it as level 4. Level 5 is outcomes improve. And level 6 is the change is sustained over time. And it's so interesting when you look at initiatives as a whole. Go back in your organization and look at your organization. Most of the time, if we get to 4, we're lucky. And 5 is rare. 6 is almost never actually asked. I mean, people don't want to say, oh, are we still doing what we said we were 2 years ago or 5 years ago? And it's so interesting to see how we have this sort of short attention span. And that's where, as we mentioned before, these shiny objects get in the way and take our attentions away. So most initiatives never really make it to the top levels. So let's go back to some of the things I've talked about, and I've sort of alluded to them here. The UP campaign that I spent an entire episode describing how it was kind of like successful in generating awareness, enthusiasm, was not at all operationally successful and didn't sustain, didn't make measurable difference. And while we got a lot of interest and excitement about it, it died there. The consensus discussion that we had before, why would people put things through a consensus process to try to generate more enthusiasm in an organization when probably, if anything else, it diffuses accountability, it diffuses that enthusiasm, makes it really difficult to take any kind of risk because it's easier to be an anchor when you have that consensus methodology. And then the pre-mortem episode where we spent a long time going in depth about how to anticipate and try to understand where failures are, the failure modes are, but then build in sort of success criteria to decide whether we're going to go forward. Because just creating a failure mode platform or analysis or whatever's happening doesn't make you successful on implementation. So those are some of the ways we looked at it. And what was different about ICU Liberation and the ABCDEF bundle is it generated durable operational change. It didn't happen overnight. You couldn't implement these in just a couple of weeks. You had to take months to do that. So success is not popularity, sadly, and it's not things that look good on the surface. What it is sustained impact with an emphasis on that word impact. Circle, highlight, underline the word impact. And I think we all want to do that, but the question is, do we actually do that? So why was the ABCDEF bundle successful? Because ownership was clear. It was owned in the ICU by the people in the ICU and led by them. And while quality departments and other people might have helped them, maybe IT helped along in the way, the ownership was clearly where the end user was, where implementation was impacting the patient. Roles were clear. And actually, role communication was really interesting how this evolved at many ICUs, so that language was standardized. Talking became a way that they could communicate more effectively about what was happening with implementation. Measures were clear. Each of the ABCDEF bundles had clear, specific measurements of success and how people were going to be effective. The evidence was clear and accountability was clear. I want to make one thing, though. I want to make sure it's clear. Not every hospital implemented every bundle element to its full potential. And that's the reality of sort of the messiness of improvement. But as I showed earlier, the more that you implemented, the better the outcomes were. And part of the reasons, it's really simple to understand. I mean, it's really hard to keep everybody walking or mobile at all the times, and you have to have personnel to be able to do it. And when during COVID happens, things slow down, and you don't get to that bundle element as often as others. So there are some. I'm not going to say that this was implemented at every ICU that ever tried it completely, fully, and walked away victorious, but overall it was successful because it made such an impact and that was measured. Let me give one example of this implementation that I actually got to witness. It was 6 hospitals in the San Francisco Bay Area, and they implemented the ABCDEF bundle with our support and coaching. And 3 of them used our method of PDSA, or rapid cycle changes, and 3 also used their sort of traditional, where they have an in-service, they go into all the different shifts, they put a policy together, they come with order sets, they implement the order sets, periodically to see how they're working. They have more in-services, sort of the traditional way to make it happen. We actually published the data on this, and what happened is that in the 3 hospitals that used that rapid cycle methodology, they got to the endpoint faster than the other method. So at 9 months, both had the same level of implementation success. The rapid cycle one got there 3 months earlier. So while that's an implementation story, the point I'd like to make today is that multiple implementation systems were successful with the bundle. So there was something inherent in the bundle itself that made it amenable to implementation. And I think there was something about these sort of 6 hospitals in a competitive environment. They wanted to all be successful in implementing the bundle. And so that's part of the reason it was also successful. So the uncomfortable reality about success is that, frankly, many organizations just celebrate too early. A successful launch isn't success. A successful presentation is nice, but it's not success. A successful webinar, it's wonderful at raising awareness, but it isn't success. A successful pilot isn't success. Real success happens when outcomes improve consistently and sustainably. So the leadership lesson, the big point, the take-home messages, I'm coming into those right now. I want you to think about these long and hard. Leaders need to be very careful about what they're measuring and what they call success. Whatever you measure and try to optimize is what's going to get measured. And so if you measure participation, like I mentioned earlier, you'll get participation. If you measure awareness, you'll get awareness. If you measure outcomes, you have a chance to improve outcomes. So why don't more organizations measure more impact? What is it about it? Why do organizations have more simple measures of success? And the real answer is that measurement is expensive or messy or just plain hard to do. So a lot of organizations settle for what I call intermediate measures of success, like participation. How many people showed up? How many patients did we say got the ABCDEF bundle? Or how many patients tried this activity? Or how many did we do for this time, but not sure if we measured whether they did it for 6 months? I mean, one of the ones we're going to talk about is how we're going to address polypharmacy in healthcare. Polypharmacy is a big problem, especially in the aged and geriatric population. And there's many studies now that show we can do a good job of reducing the number of medications. If we put our heart and soul in, we can implement polypharmacy reduction programs. And yet, 6 months later, a year later, most patients are back up to those levels. So the real question is, are we really measuring the impact? What will it take to do that? So here's what I want you to think about as we take home. What's the cost of partial implementation? Or what's the opportunity cost of partial implementation? And are these costs enough to make the ROI of a powerful measurement system of success worth it? So here's the takeaway. The ABCDEF bundle, the ICU Liberation Bundle, wasn't because it was memorable. It was memorable. It wasn't successful because people liked it. It was liked, but it was successful because it changed behavior, improved outcomes, and sustained those improvements over time. That's a much higher standard than most organizations use when they talk about success. So the next time your organization labels a project success, ask one simple question: what exactly succeeded? The answer may tell you far more about your organization than it does the project itself. So thanks for listening to Viral Healthcare. If this conversation was useful, share with a colleague who's navigating change. And if you'd like more thoughtful conversations about the ideas shaping healthcare, be sure to follow the show. We're here every Tuesday at 9 o'clock on LinkedIn Live and on the podcast platform of your choice. Look for us there. I'm Bruce Spurlock. I'll see you next time.